He's going to flow right into his second talk, which is early onset scoliosis. So let's hear it for Dr. Meier. Woo.
Okay, thank you. Good morning. So we'll start with surgical treatment of scoliosis. Now, this is not something to be meant to be specifically extremely technical or anything like that. So we're just going to talk a little bit about maybe some historical things, why we do the surgery, and go through some things there. So, and again, please feel free to ask questions in the chat, during that we can pick up then at the end of the talk. My disclosures are listed here. They do not have any relevance to this talk today. So treatment options for scoliosis, there's really only three things we can do for scoliosis. We can observe it or watch it. We can put the child in a brace, or we can do surgery on it. Those are basically our three main options. So typically observation is used if the child is mature, if they're done growing, if they have a curve less than 25 degrees. Even if they have growth remaining, we can still observe that curve. Bracing is typically used in general for curves greater than, say, 25, 30 degrees and have growth remaining. So a brace is not meant to be curative. And Dr. Nixon is going to talk more about non-operative methods of treating scoliosis later on today. But that's where bracing can be involved. And then surgery in general is for curves relatively over 50 degrees or so. And we'll kind of get into some of the whys of that as we go along. The prevalence of scoliosis, and again, we're going to talk about idiopathic scoliosis, so this is not, which basically has no real known cause, happens in about 2 to 3% of children. It has a significant female to male ratio, the higher the number of the curve. So if you have a curve of 20 degrees or less, there's typically about a 5 to 1 female to male ratio. But if you have curve greater than 30 degrees, that ratio becomes more 10 to 1 female to male. And again, that's not something that really have a good understanding of at this point of why it affects females at such a greater rate. So the natural history of scoliosis, why do we treat it? Why do we worry about it? There's some decent long-term studies that show disability, pulmonary dysfunction, pain, cosmetic deformity, and that's what we worry about. So what does the really literature say about that? So there was an article in the mid-1980s that we really refer to as the RISSER 0 study, and it evaluated the risk of progression at various stages of skeletal maturity. And so basically what this little chart shows is this is a percent of progression to surgery, these numbers here. So if you have a curve of essentially under 20 degrees, and our RISSER 2+, which is a sign of skeletal maturity, which we can see on an x-ray, it's a growth plate over the pelvis, you have a 1.6% chance of progressing to needing surgery. So if we follow that into this box down here, this lower left box, if you have a curve of 20 to 29 degrees and our RISSER 0 to RISSER 1, meaning you still have a reasonable amount of growth remaining, you have a 68% chance of that curve progressing. And that's a significant difference from if you are skeletally mature and have a lower number curve. So that just kind of proves that if you have a lot of growth remaining, you have a much higher chance of curve progression. So here's just some examples. This is one of our patients here at age 10. You can see here had a 17-degree curve. That's observation. We watched it for a while. By the age of 11, she progressed to 28 degrees. And by the age of 12, she had progressed to 33 degrees. And so that just gives you a sense of when you have a lot of growth remaining, the natural history is of relatively moderate progression over the couple years that we followed her. So contrast that with a 13-year-old girl who was already postmenarchal by at least a year with a 31-degree curvature. We follow her for a few years, and 2 years following that x-ray, she has a curve of 32, 33 degrees, which is well within a measurement variance. And you can look at that x-ray even with your eyes and say, well, that doesn't really look like it's really progressed. And that's what our measurements help us to decide that. But in a girl who's at or near skeletal maturity, there's obviously much less risk of progression. And that curve really should not progress into her adulthood. So long-term studies from Iowa, where apparently nobody leaves, they were able to follow kids and teenagers who had scoliosis into their 40s and 50s, found that curves of lower magnitude have, again, a lower incidence of progression even into adulthood. And so curves of 50 degrees or greater at skeletal maturity still progressed, and that was about a degree per year. And it does not sound like a degree per year is not much at all. But if you think of a 15-year-old with a 50-degree curve, when they're 45, which is not that old, because that's my age, that curve is going to progress by, say, 30 more degrees. Now they have an 85-degree curve, and they're 45, and that's a significant curvature that can cause them a lot of problems. And so a degree per year doesn't sound like much until you really extrapolate it over 30, 40 years of adult growth. So some Swedish studies looked at long-term studies or long-term outcomes of untreated scoliosis. They found that the mortality rates were relatively equal. Mortality was higher in infantile or juvenile scoliosis, which we'll talk about in the next talk. Curves greater than 110 degrees seem to have increasing respiratory failure, and that's an unbelievably significant curve. Surgery did seem to protect against that. The majority of people with untreated scoliosis did have back pain and osteoarthritis and slightly lower body image. So generally, we treat scoliosis because we know that higher magnitude curves have a high risk of progression in skeletally immature patients. Large curves even progress into adulthood, and these can cause long-term issues with pain, deformity, and quality of life. So we get into the surgical management of scoliosis. This is Dr. Harrington, and he originated a technique called a Harrington rod. And this x-ray is an original Harrington rod. And basically what it was a distraction rod across the curvature. And so it was essentially like a jack. Like you would jack up your car to fix your tire, he would put that rod in and jack the spine to correct that curvature. And that was one of the original techniques for treating scoliosis. And so the goal of fusion surgery is to stop the spine from curving. And that's really, Dr. Lonstein is pictured here, and he's one of my mentors. And he would always ask us during scoliosis surgeries, what is the name of this surgery? And it took a few times usually before you realized that the answer was spinal fusion surgery. It wasn't spinal correction surgery. It wasn't spinal implantation surgery. It was spinal fusion surgery. And again, the goal is to fuse the spine so that it can't keep curving. Secondary goals are improving the curvature, improving the cosmetic appearance, and you can do this from a variety of ways. We're going to really focus on the standard technique, which is a posterior spinal fusion. So as Harrington rods developed, again, this is a distraction technique, then there became some further techniques where they would be implanting, say, some hooks, as you can see on this x-ray on the right, to compress, not only distract across the inside of the curve, but compress across, say, the outside of the curve, or the convexity of the curve. And as that came along, the problems with that was a single rod did not offer any rotational control. The spine could still twist around that rod, and then it worsened your sagittal deformity. So if you look at this x-ray here, this is definitely not what you want to see, from your spine. This lateral view of the spine, it is straight flat. That is not what you want to see. And so that long term is going to put a lot of stress on the unfused segments below that rod. So later developments included these things called sublaminar wires, which are pictured here. And so these actually offered fixation at every segment of the spine as opposed to the top and bottom of the curve. And that started to introduce the dual rod or the two rod concept, where you could put a rod on each side of the spine to help control this. We still use this technique. We use some newer technologies, which includes more of a fiber or tape instead of a wire that goes around this part of the spine called the lamina, so that there's not any rigid implants in the canal. And that's made a lot of difference. And then as we went, this is probably now we're talking about in the 70s and 80s, this is COTREL-DUBOUSSET or CD instrumentation. And this really focused not only on distraction, again, across the curve, but also derotation of the spine. So scoliosis gives you a three-dimensional deformity. It's not just a curve in one plane. And so the CD instrumentation really worked on trying to help improve the alignment of the spine, both in the, say A to P direction, but also the rotation. And that rod holder that's pictured here is used to actually rotate that rod in those fixation points and give you not only a straighter spine, but also a spine that is less rotated. And so this is an earlier x-ray of that type of instrumentation, with the dual rod, again, technique to help control that rotation. And so a clinical photograph, which we'll see here, I think in a few, will also show the rotation of the spine much improved. So fixation of these rods to the spine is often done through these different ways with hooks. And these are still used today. These are a little bit of an older type of fixation, but they're definitely still used today. And so they attach to different parts of the spine to help hold that rod directly to the spine. And so this area of the spine here called the pedicle, which is be important as we talk about screw fixation. So this is the posterior aspect of the spine and the anterior aspect of the spine in green. And so those hooks usually go into the posterior aspect and they attach to the pedicle or attach underneath the lamina to help hold the rod in place. And so here's that clinical photo I was talking about where you can see the rib hump on the forward bend test here on this patient, where the right side is significantly higher than the left of the patient because of the rotation of the spine, and now after surgery that has markedly improved after the derotation. So now we kind of come up to more modern day. So this started in around the 1980s and 70s, but basically Dr. Suk in South Korea essentially originated the technique of pedicle screws, and these are pictured here. And so we've been using these since around the 70s, early 80s, and these provide what we call 3-column fixation of the spine. So they go in from the back and they traverse the pedicle, and there'll be some diagrams and pictures of that. And this provides a very rigid construct. And so the modern techniques that we use today for spine surgery are really reliant on these pedicle screws to help with rigid fixation of the spine, and we can mobilize the spine really very well using these. So the anatomy of the pedicle screw, this is looking, say, straight down on the spine, and this nice yellow thing here, that's the spinal cord. And so the pedicles are seen here on either side, and we use these instruments called awls or a drill to probe the pedicle bluntly, and they're angled as you go into the pedicle to avoid the neural canal and then get into the front of the spine here. And so this technique of 4 walls and a floor, basically once we make this track in the pedicle, we use a little feeler probe and we try and make sure that we have 4 walls and a floor. And if we don't have 4 walls, we can see that, or we can know that we are out somewhere. And usually that is not something disastrous, but we can remake a track because this is done slowly by hand, and it's usually can be done in a very safe manner. So a fusion technique now then is you're attaching these rods to the spine. The rods hold the spine really rigid to allow fusion. So what I usually tell parents and kids is basically the rods act as a cast. So if you have a wrist fracture, you put your arm in a cast and that holds the wrist still while the bone heals it. So the rods do the same thing for the spine. They hold the spine very stiff and rigid, and so that your own bone can fuse that spine, essentially gluing it together, and then that fuses and holds the curve where it belongs. Now the rods also, again, offer correction. We can improve the appearance of the spine and improve the rotational deformity as well. So when we talk about rods, the rods that we use are typically mostly cobalt chrome, which is something between a stiffness of stainless steel and titanium. Titanium rods are used often in adult surgery for different reasons, but they don't have quite the stiffness to hold the spine in the proper position for a scoliosis surgery. So typically a stainless steel or cobalt chrome rod is used. And these are some rod benders. So you can see here, this is bending the rod into the proper position for correction of the spine. Again, we don't want the spine to be flat on the side view. We want there to be normal thoracic kyphosis and normal lumbar lordosis, and that's what bending the rod helps us to accomplish. So the goals of spinal fusion, again, I put this in bold, are stopping the curve progression. We want to stop the curve progression. Goals underneath that are to improve it, to decrease the rotational deformity, improve the spinal balance. So if they have a big trunk shift, they're leaning one way or the other, we're trying to improve that. And again, maintaining the proper kyphosis and lordosis. So here's just an example of a child with a typical right thoracic scoliosis and a fusion surgery using screws and some clamps here to hold the spine. And again, we have overall good spinal balance, meaning the head is centered over the pelvis. The curve, there's still a curve there. The spine will still have a little bit of curve, but it's much more stable and much better aligned. So what's the risk of a big spine surgery like this? These are probably the biggest surgery that most of us perform. It's very long, and there is some risk to it for sure. So safety is paramount. When we're operating on a child's spine, there's no question that the outcome that we have to have is a child who walks out of the hospital doing well. So the risks of surgery we talk about are blood loss, infection, neurologic injury, and failure of fusion are really the main risks. So what are the risks of this? So most commonly is infection. And so here's an example of a patient who has an infection over some hardware here that needs some treatment. So this happens about 2 to 3% of the time in idiopathic scoliosis. In neuromuscular scoliosis, which I think Dr. Walker will talk about later on, that has a higher complication rate for various factors, but in general, it's a 2 to 3% risk roughly for idiopathic scoliosis. And these frequently require a secondary washout and reclosure. It is treatable, but I'm telling you, it is no fun for the surgeon or especially the patient and the parent. So it's something we're very clear about. If you have an infection, that's a bad problem. You need repeat surgery to clean that out, to wash it out, reclose it, and it's very treatable, but it's not something that we ever want to see. So neurologic injury is probably the thing that most kids and parents are worried about. It's really probably the biggest thing that they worry about. Now the good news is that it is extremely rare. It's less than 1% of the time. And even if there is sometimes a neurologic injury, it's typically not a complete neurologic injury, meaning paraplegia or paralyzation. That's unbelievably rare. One of the ways that we try and avoid this is with live neuromonitoring. So this is a standard of care with scoliosis or spinal deformity treatment surgery. Is live neuromonitoring involves a neuromonitoring technician whose sole job in the room, in the corner of the room, is to attach monitors to the patient prior to starting the surgery and monitor the spinal cord function. And we can actually ask them to run what's called a motor test, is where they actually stimulate the spinal cord at the brain and pick up the responses in the feet. And so they can tell us motors are still present, meaning, yep, everything's still functioning normally. If we try and overcorrect the spine, if we do something where one of our screws is too close to a nerve root or something like that, they can actually pick that up and say, hey, the spinal cord responses are a little decreased. We might want to take some correction off. We might want to raise the blood pressure. There's a whole protocol we go through to make sure that we don't cause any neurologic injury. And so again, luckily that's extremely rare in idiopathic scoliosis. So one thing that also helps our safety is some improvements in screw placement. So this is just a diagram, again, of what we call an axial, or looking down at the spine to where those pedicle screws go. And usually these pedicles are anywhere from 5 to 10 millimeters wide. And so these screws typically range from a typical screw size would be a 4 millimeter to a 5.5 millimeter screw diameter. And so you can see from this CT scan here, luckily not ours. This is, you can pull these up on Google, but this is not any of ours. But this pedicle screw here is not where it belongs. And you can see that nice big round structure there. That's the aorta. And so you can be close to those structures if you're not really paying attention. Even if you are paying attention, which we always are, that can be a little closer for comfort. So, and one of the ways we can, or one of the things that makes it difficult sometimes is if you have a small stature patient, if you have some anatomical variation, some of these pedicles are very narrow and very small. And again, they aren't close to important structures. So there's a couple different methods that we can use to help improve our screw placement and improve our safety. Typically, we use live X-ray or fluoroscopy during screw placement. We can usually see these pedicles relatively easily under live X-ray, and that can help guide our placement of them. We can use CT guidance. We can also use 3D printed guides. So I'll just touch a little bit on a few of these things. A CT guided is an intraoperative low-dose CT scan with a machine that's brought into the OR. There's a live CT scan done. The instruments are navigated, and the computer program takes that CT scan, and does a 3D modeling of that. And so here's some examples of what that looks like virtually. So the purple and pink here, those are the virtual, what the computer knows you're using this diameter screw, this length, and this is where the computer says you are going. And so you can use that to help guide your trajectory down the pedicle, and you can look at all the different views that you need to. You can check your diameter, check your length, and those, the colored instruments here are navigated instruments, and the computer basically knows exactly how big those instruments are, what shape, what size, that kind of thing. And so that's really very helpful for kids who have maybe some narrow pedicles, some altered anatomy, those kinds of things. So 3D printed guides is another technique we can use. This is based on a preoperative CT scan of the spine. And the spine is actually printed with a 3D printer. It's sterilized, and we can actually bring it into the operating room and look at it with the patient sitting right there and kind of compare that 3D printed model to the patient's actual spine. And then screw guides are printed as well, and they actually can be placed directly on the spine and help guide our screw placement. And so here's just an example of what that might look like, again, with the spine, and that's the guide on top of the spine that literally attaches to the bone at every level. And here's some just examples of what that looks like in surgery, where the guide is actually on top of the bone of the spine, and those little cannulas there guide your placement, and that's what the spine actually looks like intraoperatively. And you can actually hold that next to the spine so you know exactly what your anatomy looks like. So here's an example of one of our patients, a 13-year-old with a syndrome. And if you look kind of closely here, these little areas here are the pedicles. On this part of the spine here, due to the rotation and some of the anatomical differences, you can't see those pedicles at all. They have to be there, but you just can't see them under x-ray. And so this was an example where we felt the 3D printing would be helpful to us. And so we were able to place those screws and get some good correction there, just by being more confident that our screws were going in the right place, even if we couldn't necessarily see them under the live x-ray. And so that's kind of a little before and after. So screws versus hooks, why would we use one versus the other? There is still a little debate. I think there's definitely a place for all of these implants. If you want to do the best surgery you can, you need to know how to use all of these implants. Screws do offer increased rigidity, more powerful correction techniques, that kind of thing, but there's really no proven benefit to the final patient outcome using screws versus using hooks. One of the cons with screws, this is one of the best quotes I've heard from one of our mentors: "I never put a hook into someone's aorta." That's something that's definitely worth thinking about. In addition to that, you have the cost. Pedicle screws are very expensive. Spine surgery is probably one of the most costly surgeries that we can do, and there's a lot of debate and research being done right now to determine what is the optimal amount of implants that gives you a good clinical outcome that doesn't make it exorbitantly expensive. Oops, sorry. So again, here's just some thoughts on these screws. And again, these are not our pictures. You can get these off of Google. I don't know why people would put them on there, but here's a pedicle screw that's going a little medial, and that's the canal right there. So that's quite close to the nerve roots in the spinal cord. Here's one that's too long, and there's your aorta right there. So there's definitely some things you have to think about when you're putting these in. So the rod construct, again, 2 rods provide rotational control. And so I put growing rods in there, which we'll talk in the next talk about, because the Harrington rod construct, that single rod, did not offer much rotational control. And we'll talk about that some with growing rods also. Your rod contour tries to match your ideal sagittal profile, which is your side view. And so you want that proper thoracic kyphosis, lumbar lordosis for the long-term health of your spine. Because what you are doing is you are taking motion from the spine. You are stiffening the spine and fusing it. And so one of the drawbacks is that you lose motion. Depending on where it's fused, you will lose some rotational motion. You'll lose some bending motion. So there's definitely drawbacks to a fusion surgery. So, and this is just another case. This is a 62-degree right thoracic curve. And you see this lumbar curve here is 38 degrees. But if you look at these, what we call bending films, and you can see that the right thoracic curve is relatively stiff, but look how flexible that lumbar curve is. So, and we said, well, we don't necessarily need to include that in our fusion. We could leave that lumbar curve alone and let them have motion, let them have bending. And so we did a fusion of the two curves up top. And again, you can see there's still curvature there, but we do that on purpose to allow the spine to be balanced. So in effect, the head is still and trunk is still centered over the pelvis. And it's much better to have some residual curve and have some lumbar motion than to make the spine look nice and straight on x-ray and fuse it down to the bottom and have no motion at all. So in conclusion, we would like a fusionless treatment. That would be preferable. You don't want to have spine surgery. I would not want my teenage daughter to have a scoliosis surgery. Nonetheless, the true long-term outcomes are really unknown in that we don't have, say, 30, 40-year-old follow-up on the techniques that we are using because they're really only about 30 years old at this point, the current really modern techniques. And in the end, spine surgery can be done very safely, very reliably, and still has definitely a place for treatment of scoliosis today. So thank you. That's the end of that talk. So we will escape and go back here.
While he's pulling up his next talk, I just want to say that I would, if my child had to have scoliosis surgery, I'd definitely want to have it done by someone who is as caring and cautious as you are, which comes through nicely in your talk. So I appreciate all your discussion about all the different implants and techniques, and clearly the consideration you give to everything you're doing there is wonderful.